Ever had that weird experience where your fingers suddenly go stark white in the cold, maybe turn a bit blue, and then get all flushed and red? Okay, let's unpack this because we're taking a deep dive into something called Raynaud Phenomenon.
Yeah, and what's fascinating here is that while you might have heard it called Raynaud's disease, our sources actually point to Raynaud syndrome, or RS, as the more accurate term nowadays.
Right.
So our mission today is to really understand what RS is all about, what sets it off, the crucial distinction between primary and secondary types, and the ways it can be managed.
Exactly. We've got a really thorough chapter from a vascular surgery textbook guiding us today. So if you ever notice these color changes yourself, or you're just curious about why your body might react so strongly to cold or stress, well, you're in the right place. We're going to break it down and hopefully give you some real insights.
Okay, so to get us started, back in 1862, a physician named Maurice Raynaud first put his finger on this, so to speak. He observed this connection between, cold exposure or strong emotions and these recurring episodes of reduced blood flow, specifically in the fingers of certain individuals.
Right, and the way our source describes it is as an exaggerated version of a normal body response. Like, think of it like your body's usual reaction to cold, those blood vessels narrowing slightly to conserve heat, just going into overdrive.
Exactly.
This causes those distinct color changes. First, pallor, the whiteness, then cyanosis,
That bluish color, yeah.
the bluish color as the blood loses oxygen, and then finally rubor, the redness as the blood flow returns when you warm up. And it's not just fingers, right? It can happen to your toes, too.
That's right, toes as well. And what's important to clarify is the naming history. For a long time, Raynaud's disease was the common term, But as understanding grew, Raynaud Phenomenon emerged to differentiate between cases that seemed to occur on their own.
Kind of out of the blue.
Yeah, versus those that were a symptom of another underlying health problem.
And that's where the primary and secondary classifications come in, right? Our source makes it really clear that primary RS is the more common form.
Mm-hmm.
It's considered idiopathic, meaning the exact cause isn't known.
Mm-hmm.
It's generally benign, and there aren't any structural changes to the blood vessels themselves. Interestingly, the source mentions that up to a third of people with primary RS might even see their symptoms just disappear over time.
Precisely. Now, secondary RS is a different ballgame entirely. This is when Raynaud syndrome is linked to another underlying medical condition, such as, say, systemic sclerosis or rheumatoid arthritis. These are types of connective tissue diseases, or CTDs.
Okay.
In these situations, there's often some degree of fixed narrowing or even blockage in the blood vessels, which makes them much more sensitive to cold. And this can unfortunately lead to more serious issues like digital ulcers, scarring, and in severe cases, even gangrene. And it can be associated with earlier mortality in some individuals.
So a really significant distinction between the two. Now, how widespread is Raynaud syndrome in the population? Is it common?
Well, the prevalence actually varies quite a bit depending on geographical location and even ethnicity, likely due to, differences in climate. But general estimates range quite widely, from about, say, 3% to as high as 22% of the population.
Wow, it's a huge range.
Right.
What might account for that variability? Is it purely temperature related or?
Temperature is a big part, definitely. And women are significantly more affected than men. Prevalence in women can be anywhere from 2.5% up to 21%, whereas in men it's lower, between maybe 0.5% and 8.3%. There have also been a couple of longer-term studies looking at how frequently primary RS develops. A study in France found an annual occurrence of about 0.25%, and the Framingham Offspring study reported around 2.2% in women and 1.5% in men over a 7-year period. So it does pop up.
Okay, so primary RS seems relatively common and often not too serious in the long run. But secondary RS definitely carries more significant risks and warrants close attention. Now, to get a better handle on why this happens, it's probably helpful to understand what normal blood flow in the hand looks like, right? Like, what's the baseline?
Absolutely. The circulation in your hand is actually quite a clever bit of engineering. You've got these interconnected networks of blood vessels called the deep and superficial arches. Think of it like a road network with multiple routes, maybe?
Okay.
These arches then feed into the metacarpal arteries and finally the proper digital arteries that run along your fingers. Now, in most people, both of these arches contribute blood to all 5 fingers, providing a crucial backup system, or what we call collateral flow, between the radial and ulnar arteries in your wrist.
Backup systems are always good when it comes to blood supply.
They absolutely are. However, our source points out that in about 21.5% of people, the superficial arch might be incomplete, like having a less complete road network, to stick with the analogy. In those cases, if either the radial or ulnar artery gets blocked, it could potentially lead to a more severe lack of blood flow, or ischemia, in the fingers. It's also interesting that each finger typically has two digital arteries running along its length, which is, another layer of protection against losing blood supply. And right at the very tip of your finger, there's a super dense network of these tiny vessels.
Makes sense, especially with all those nerve endings. They're very sensitive to touch and temperature. So how does our body normally regulate all this blood flow in our digits? What's the control system?
Well, the blood flow in your fingers is incredibly adaptable, kind of like a tap that can go from a tiny drip to a full-on stream. The source says it can vary from just 1 LNL per minute up to 180 millimollar per minute per 100 millimollar of tissue. Huge range.
Wow.
And it serves two main purposes. First, delivering nutrients to the tissues, that's the nutritional aspect. And second, playing a major role in regulating your body temperature that actually accounts for a large majority, around 80 to 90% of the blood flow in your fingers.
So when you're feeling warm, those blood vessels near the surface of your skin dilate to release heat, and when you're cold, they constrict to conserve it. Basic stuff, right?
Exactly. The source mentions that the maximum constriction happens when temperatures are between 10 and 20 degrees Celsius. And then, at even lower temperatures, something quite fascinating occurs called cold-induced vasodilation, also known as the hunting response.
Well, hunting response.
Yeah, it's where the vessels actually slightly reopen in cycles. This allows a small amount of blood flow back in to prevent the fingers from actually freezing. It's a protective mechanism. However, this protective mechanism is often impaired in people with secondary RS because of those underlying issues, the structural disease in their arteries.
Interesting that the body has this built-in safeguard against freezing, even if it doesn't always work perfectly in some conditions. Now let's get to the core of it. What's actually going on in the body that causes Raynaud syndrome? What's the why behind it all?
That's the big question. And the truth is, the precise cause still isn't fully understood. The source highlights that it's likely a complex interplay of factors involving, well, the blood vessels themselves, the nervous system that controls them, and certain substances circulating in the blood, what we call vascular, neural, and humoral factors.
Okay.
Early on, the thinking was maybe it was simply an overactive sympathetic nervous system, that fight-or-flight response kicking in too easily in the cold. But then research showed that even blocking the nerves in the fingers didn't always stop the vasospasms.
So not just nerves then?
Right. Later, the idea of a local vascular fault, where the blood vessels themselves were just inherently more sensitive to cold, gained traction. Now, the understanding is much more nuanced, with multiple pieces contributing to the puzzle.
Okay, so let's break down these contributing factors. First, the vascular side of things. What's happening with the blood vessels themselves in Raynaud's?
Okay, on the vascular front, there seem to be issues with both vasodilation, the ability of the vessels to widen, and vasoconstriction, their tendency to narrow too much. When it comes to impaired vasodilation, the cells lining the inside of the blood vessels, called endothelial cells, play a crucial role.
The endothelium.
Yes. They produce several substances that help relax the vessels, like nitric oxide, prostacyclin, ATP, and bradykinin. Think of these as the body's natural ways of telling the blood vessels to, open up.
And nitric oxide, or NO, is a big player in vasodilation, right? I remember hearing about its importance in other areas of health.
It is, absolutely. It's synthesized from an amino acid called L-arginine and helps the smooth muscles in the vessel walls relax, allowing for better blood flow. The source notes that decreased levels of NO have been found in patients with both systemic sclerosis and Raynaud syndrome. Also, there are these active forms of NO called S-nitrosouthiols, which are also reduced in these conditions. And interestingly, in secondary RS, there can be decreased levels of something called asymmetric dimethylarginine, which actually inhibits the enzyme that produces NO. So in essence, in some forms of Raynaud's, the body has less of the raw materials it needs to produce that vital relaxing signal.
That makes sense. What about the other side of the coin, increased vasoconstriction? What's driving that overactivity?
Here, the endothelial cells also produce substances that cause vessels to contract, most notably endothelin-1, or ET1. This is a very potent vasoconstrictor.
Potent.
Very. And it can also promote the growth of cells in the vessel walls, potentially contributing to the structural changes seen in secondary RS. Plasma levels of ET1 rise in response to cold, suggesting a link to cold-induced vasoconstriction. Some studies have even reported a threefold increase in ET1 in primary RS. However, It's important to note that more recent research has presented conflicting evidence on just how significant this relationship is, so the picture is still being refined.
Interesting how scientific understanding evolves as more research comes in. What about other vasoconstricting factors? The source also mentioned angiotensin.
Yes, angiotensin is another peptide that has vasoconstrictive effects and has been implicated in RS. While the exact mechanism isn't fully clear, increased levels of angiotensin II have been found in patients with scleroderma. However, it doesn't seem like the renin-angiotensin system, which is responsible for producing angiotensin, is activated in primary RS, so it seems more relevant maybe for the secondary types.
Okay, so that covers some of the vascular aspects. What about the neural factors? How do our nerves play a role in Raynaud syndrome?
The current thinking really emphasizes alterations in the activity of adrenoceptors in the peripheral nervous system. These are like docking stations on the blood vessel walls that respond to certain nerve signals. Early studies showed that blocking nerve signals in the fingers could reduce cold-induced vasospasm, suggesting that the adrenergic receptors, which respond to neurotransmitters like norepinephrine, might be involved.
And norepinephrine is part of the sympathetic nervous system, the fight or flight response,
Yeah.
right? So stress or cold could trigger its release.
Exactly. Sympathetic nerves can release norepinephrine in response to cold or emotional stress, and this acts on the alpha-2 receptors on the smooth muscle cells in the blood vessel walls, causing them to contract and narrow the vessels. Now, what's key here is that cold actually increases the affinity of these alpha-2 receptors for norepinephrine.
So it makes it stickier.
Kind of, yeah. It makes the vessels even more sensitive to its constricting effects in cold temperatures. This process also involves something called Rho protein kinase signaling, which is a kind of intracellular communication pathway that amplifies the contraction signal.
So the cold makes those receptors even more eager to grab onto the norepinephrine and squeeze the vessels shut.
That's a good way to put it, yes. There was even a study where they introduced drugs that block alpha-1 and alpha-2 receptors into the arm during cold-induced attacks. Blocking the alpha-2 receptors led to significantly fewer attacks compared to blocking alpha-1 receptors, really highlighting the importance of alpha-2 in this process.
Okay.
However, like with ET1, there have been some mixed results with specific alpha-2 subtype blockers in certain conditions, like systemic sclerosis, so the precise role of each subtype is still being investigated.
Science is rarely simple and straightforward.
Uh,
Now let's move on to humoral factors. What are those exactly?
Humoral factors encompass a range of things circulating in the blood that can influence blood vessel behavior. This includes hormones, genetic predispositions, the activation of platelets, those tiny cells involved in blood clotting, and factors involved in blood clotting and breakdown like fibrinolysis.
Okay.
The source notes that Raynaud syndrome is much more common and tends to be more severe in women, particularly between menstruation and menopause. This strongly suggests a potential role for hormones. There's some evidence that women might have a higher baseline level of sympathetic nervous system activity and naturally reduced blood flow in the skin compared to men. Also, lab studies have shown that estrogen might potentially increase the number of those alpha-2 adrenoceptors we just discussed, making blood vessels potentially more reactive.
So hormonal differences could be a key reason why women are more susceptible.
Mm-hmm.
What about genetics? Does Raynaud's run in families?
Well, about 25% of people with primary RS report having a family history of the condition, so there's likely some genetic component involved. However, it's often tricky to separate out genetic factors from shared environmental factors within families.
Sure, nature versus nurture.
Exactly. While many different regions of our genetic code have been looked at, no single significant genetic difference has consistently been found between people with RS and those without. It seems to be a more complex, probably multi-gene issue rather than one single gene causing it.
Interesting. What about platelets and blood clotting? How do they fit into the picture?
Activation of platelets and increased levels of serotonin, a neurotransmitter that platelets carry, have been observed in RS patients. Exposure to cold can actually trigger the release of activated platelet products like thromboxane and beta-thromboglobulin.
And those make things worse.
They can contribute to vasoconstriction and potentially to the stickiness of blood, making flow harder. The exact role of serotonin itself in RS is still being investigated. It's not entirely clear. When it comes to fibrinolysis, which is the body's process of breaking down blood clots, abnormalities seem to be more strongly linked to secondary RS.
Oh, okay.
For example, elevated levels of a substance that inhibits the breakdown of blood clots have been found in scleroderma. This impaired ability to clear clots could potentially contribute to the fixed vascular obstruction seen in that condition.
So lot of different factors potentially at play interacting in complex ways, and it probably varies quite a bit from person to person. Now, are there specific risk factors that might make someone more likely to develop Raynaud syndrome?
Yes, there are several identified risk factors. We've already touched on genetic factors through the higher prevalence in women. Occupational factors are also significant, especially something called vibration-induced Raynaud phenomenon, or vibration white finger.
Oh, yeah, I've heard that.
It's been recognized for over a century. Millions of workers who regularly use vibrating tools, think jackhammers, chainsaws, grinders, are at risk. Chronic vibration can cause actual structural damage to the arteries in the hands and fingers and also lead to overactivity of the sympathetic nervous system.
Okay, what else?
Certain drugs are also known culprits associated with RP as a side effect. Beta blockers are one example. Incidence has been reported as high as 40% in some studies, although, many people tolerate them just fine without any issues. Other medications that can potentially trigger RP include some chemotherapy drugs like cisplatin, vinblastine, blumycin, bromocriptine, which is used for Parkinson's and other conditions, amphetamines, cocaine, ergot preparations sometimes used for migraines, and even some of the newer tyrosine kinase inhibitors used in cancer treatment. It's quite a list.
It really is. What about lifestyle factors like smoking and alcohol?
The relationship with smoking is a bit nuanced. Some studies have found an association in men, particularly those who also have other cardiovascular risk factors, but it's been less consistently observed in women. However, a broad meta-analysis did suggest a slightly increased overall risk of Raynaud's with smoking, maybe an odds ratio of around 1.27.
So probably best to avoid it.
Generally good advice anyway. Interestingly, alcohol has actually been reported to have an inverse association in some studies, suggesting it might be protective, with an odds ratio around 0.33. But more research is definitely needed to confirm that. Cannabis use has also been reported as a potential association with Raynaud's in some cases.
That's a pretty comprehensive overview of risk factors. Now, we talked earlier about secondary RS being linked to other diseases. What are some of the more common conditions that Raynaud's can be a sign of?
Right. Secondary RS is often a signal that there's an underlying condition causing a fixed narrowing or obstruction of the digital arteries, which lowers the pressure threshold for vessel closure. It's very commonly associated with connective tissue diseases, or CTDs. Scleroderma is a big one.
Where the skin gets tight.
Exactly. And changes in the blood vessel walls lead to that narrowing, intimal hyperplasia, thrombosis, fibrosis. Other examples include rheumatoid arthritis, lupus, Sjogren's syndrome, dermatomyositis, several others that are source lists.
Okay.
In a large study looking at many patients with Raynaud's, while over half had the primary form, a CTD was the most common underlying issue in those with secondary RS, with scleroderma being the most frequent culprit. Less common associations include things like atherosclerosis, Berger disease, which is an inflammatory condition affecting small and medium vessels, often linked to smoking certain cancers. Yeah, particularly adenocarcinomas and hematologic malignancies have been linked in some cases. The mechanisms aren't fully clear, but could involve things like causing blood clotting problems, coagulopathy, producing abnormal proteins in the blood, cryoglobulinemia, or triggering inflammation of small blood vessels, vasculitis, and of course the vibration-induced white finger we mentioned.
So if someone is experiencing these Raynaud-like symptoms, it really underscores the importance of considering whether there might be an underlying medical condition that needs to be identified and addressed. Now, how does a doctor actually go about figuring out if someone has Raynaud syndrome? What are the clinical findings they look for?
Diagnosis is primarily based on a careful gathering of the patient's medical history. It really hinges on that story. The key indicators are those recurring attacks of pallor whiteness affecting part or all of the fingers that are clearly triggered by exposure to cold or sometimes emotional stress, and typically resolve relatively quickly, within minutes, usually less than 10 to 20 upon rewarming. While it most commonly affects the fingers, the toes can also be involved in up to maybe a third of patients.
Now, I remember reading something quite specific about the thumbs. Is that right?
Yes, that's a really helpful clinical clue. In primary RS, the thumbs are frequently spared from the color changes. If the thumbs are involved in the attacks, it's actually more suggestive of secondary RS.
Interesting detail.
It is. The frequency of attacks can vary quite a bit between individuals, from several times a day to just a few times a week, and they tend to be more common during the colder winter months, naturally. Interestingly, pain is usually not a prominent feature during the whiteness or bluish phase in primary RS, possibly linked to that cold-induced intermittent vasodilation, the hunting response we discussed earlier.
Sure.
Raynaud syndrome can also sometimes occur in association with other conditions involving blood vessel spasms, like Prinzmetal angina, that's chest pain due to coronary artery spasm and migraine headaches, suggesting maybe a common underlying tendency for blood vessels to overreact in some people. In contrast, people with secondary RS, who often have those underlying fixed narrowings in their arteries, are more likely to experience pain in their fingers, particularly when they rewarm, because their blood flow simply can't increase adequately to meet the tissue's oxygen needs after the spasm.
Okay, so a detailed medical history is really the starting point. But are there any specific tests or procedures that doctors use to help diagnose Raynaud syndrome or differentiate the types?
Well, while there's no single definitive diagnostic test, our source outlines some suggested criteria that help in diagnosing primary RS specifically. These include the characteristic cold or stress-triggered vasospastic attacks affecting both hands, though maybe not simultaneously or in the exact same fingers, the absence of any signs of tissue damage like ulcers or gangrene,
Right, no tissue loss.
no tissue loss, no indication of a secondary underlying cause from the history or exam, normal-looking capillaries when examined under the fingernails, we'll get to that, and negative results on certain blood tests, particularly for anti-nuclear antibodies or ANA.
And the physical examination must also play a vital role in the diagnostic process, right? Especially for picking up those secondary causes.
Absolutely crucial, particularly for trying to differentiate between primary and secondary RS. During the physical exam, the doctor will pay close attention to the vascular system, checking for any signs of blockage in large, medium, or small blood vessels. They'll palpate pulses from the upper arm down to the wrist.
Like the radial and ulnar pulses.
Exactly. And they'll perform the Allen test, which helps assess for any blockage in those arteries at the wrist and also checks to see if the network of vessels in the palm of your hand, the palmar arch, is fully complete and providing good collateral flow.
Okay.
They'll also look very carefully for any physical clues that might suggest an underlying connective tissue disease. This involves examining the skin for any signs of thinning, tightening, sclerodactyly, that tight, thick skin on the fingers, telangiectasias, those little spider veins, any existing ulcers, or even just thickened skin, hyperkeratosis, that might indicate previous healed ulcers. They might also look for splinter hemorrhages under the nails, although these can sometimes be normal in people who do a lot of manual work, so you have to interpret that cautiously.
What about those non-invasive vascular lab tests we sometimes hear about? What information do they provide?
These tests serve as an important addition, an adjunct to the clinical evaluation. They can help determine if the issue is primarily due to vasospasm or if there's also a component of fixed arterial obstruction. They can also help assess the location and severity of any circulatory impairment. But it's really important to remember that no single lab test can definitively diagnose RS. They don't replace a thorough medical history and physical exam.
So they add pieces to the puzzle. What are some examples?
Some of the useful tests include measuring blood flow or perfusion in the arm, hand, and individual fingers at room temperature. Also measuring digital temperature, systolic blood pressure in the fingers using tiny cuffs, and using a technique called laser Doppler to assess blood flow both before and after locally cooling the fingers.
And are there more specialized tests for looking at larger blood vessels versus the very small ones in the fingers?
Yes, techniques like segmental pressure measurements, taking blood pressures at different levels of the arm, and duplex ultrasound can be used to evaluate for blockages in the larger arteries, like the subclavian or brachial arteries. A significant difference in pressure, say more than 10 millimilli Hg, between segments might suggest a problem upstream.
Okay.
While traditional ultrasound has had a more limited role in directly visualizing the very small digital arteries in RS, a newer technique called power Doppler ultrasound is showing more promise in this area. One study even suggested it had good diagnostic accuracy when compared to examining the capillaries under the fingernails.
And for the tiny finger vessels?
For the smaller vessels in the fingers, measuring the systolic blood pressure using those small digital cuffs can be helpful. A significant drop in pressure, maybe more than 15 millimilli Hg between different fingers, or a very low absolute pressure, like below 70 millimilli Hg in a finger, might indicate a fixed obstruction. Also, looking at the waveforms produced by a technique called plethysmography, which measures changes in blood volume.
Of the shape of the pulse wave.
Exactly. That shape can provide clues. Blunted, flattened waveforms might suggest obstructive disease, while sometimes a very sharp, peaked pulse pattern can be seen in purely vasospastic RP.
And what about those cold challenge tests that involve immersing the hands in cold water? What do those tell doctors?
Ah, yes, the cold challenge. These tests typically involve immersing the hands or fingers in cold water for a short period, maybe 20 seconds in water at around 4 degrees Celsius, and then carefully measuring how quickly the temperature of the fingertips recovers back to the baseline temperature.
So looking at the rewarming time.
Precisely. A significant delay in this rewarming process, often defined as taking longer than 10 or maybe even 30 minutes, can suggest an increased tendency for vasospasm. Now, while these tests can be quite sensitive, meaning they're pretty good at identifying people who do have RS, they're not as specific. Meaning they might sometimes give positive results in people who don't actually have the condition or have some other reason for poor circulation. This lack of specificity limits their routine use as a standalone diagnostic test. Sometimes this cold challenge is combined with photoplethysmography, or PPG, which measures blood volume changes using light.
Now, you mentioned looking at the capillaries under the fingernails earlier. That sounds interesting. How is that done, and what are doctors looking for?
That's called nail fold capillary microscopy. It's a non-invasive technique, pretty simple actually. A drop of immersion oil is placed on the cuticle at the base of the fingernail, and then the area is examined under a low-powered microscope or a special device called a capillaroscope.
And what do you see?
In healthy individuals, you typically see these neat, regularly arranged, hairpin-shaped loops of capillaries, very orderly. However, in conditions like scleroderma and other mixed connective tissue diseases, these tiny blood vessels can look quite abnormal. They might appear enlarged, dilated, twisted, tortuous, deformed, or you might even see areas where the capillary loops are missing altogether drop out.
Wow.
And interestingly, if someone who doesn't have a known connective tissue disease presents with Raynaud's and shows these abnormal nail fold capillaries, it's actually a strong predictor that they might go on to develop a CTD in the future. One study found about 80% of such patients developed a CTD over about 6.5 years.
That sounds like a really valuable test, then, for potentially identifying secondary causes of Raynaud's early on, or predicting risk. And finally, what about blood tests? Serology. What role do they play in diagnosis?
Serologic evaluation or blood tests can be very helpful, mainly in confirming a diagnosis of an underlying connective tissue disease and in screening for other potential secondary causes of Raynaud's. The most commonly used tests include looking for anti-nuclear antibodies, ANA, and rheumatoid factor, RF.
ANA and RF.
Right. An ANA test is positive in a very high percentage, maybe 90–95% of people with systemic sclerosis. However, it's important to note that a positive ANA result isn't specific just to scleroderma. It can be seen in other autoimmune conditions, even sometimes in healthy people. So a positive ANA raises suspicion, but it doesn't definitively confirm the diagnosis on its own. Rheumatoid factor is a marker that is often elevated in people with rheumatoid arthritis, another potential cause of secondary RP.
So it sounds like a combination of a detailed medical history, a thorough physical examination, and then targeted use of these different vascular tests. Nail fold capillaroscopy and blood tests helps doctors to get a clearer picture, differentiate primary from secondary, and make a diagnosis. Now, if someone is diagnosed with Raynaud syndrome, what are the available treatment options? How is it managed?
Treatment for Raynaud syndrome really needs to be tailored to the individual. It depends on several factors, including, whether it's primary or secondary RS, how severe and how frequent the symptoms are, whether there's an underlying medical condition that also needs to be treated, and the overall risk of developing complications like digital ulcers.
Makes sense.
For many people with primary RS, often just implementing preventative measures and lifestyle changes is sufficient. Broadly speaking, there are three main approaches to treatment. First, non-pharmacologic behavioral therapy. Second, the use of medications or pharmacologic treatment. And third, surgical or interventional procedures. And of course, in cases of secondary RS, treatment will often also involve addressing the underlying autoimmune condition, which might include the use of immunosuppressant medications.
Let's start with those non-pharmacological approaches. What kind of preventative measures and behavioral therapies are typically recommended?
Education and reassurance are really key first steps, especially for primary RS, which is often benign. Avoiding exposure to cold is paramount. This includes simple measures like wearing warm layers of clothing, especially good gloves and socks, maybe using hand warmers, and just being mindful of cold environments or activities that tend to trigger attacks.
Common sense stuff, mostly.
A lot of it is. Interestingly, gloves made with ceramic impregnated fabric, which are thought to reflect infrared heat back to the hand, have even shown some benefit in studies. It's also important to avoid any substances that are known to cause blood vessels to constrict. That means avoiding nicotine, so quitting smoking is crucial, and being aware of certain medications that can exacerbate symptoms, like some decongestants or the ones we listed earlier.
Right. What about those behavioral therapies like biofeedback that some people try? Does that work?
Temperature biofeedback is a technique that aims to teach individuals how to consciously try and regulate the temperature of their skin, particularly in their hands and feet, often using visual or auditory feedback from a temperature sensor. The idea is that by learning to control this physiological response, they might be able to prevent or even lessen Raynaud's attacks.
Can people really do that?
Well, studies on the effectiveness of temperature biofeedback have yielded mixed results. Some trials showed some benefit, but meta-analyses have suggested it might not be significantly better than a placebo in reducing symptoms overall. The literature is kind of inconclusive, so it's not a mainstay of treatment, but some people do find it helpful.
Okay, so the evidence for behavioral therapies might be a bit inconclusive at this point. What about medications? When are those typically considered for Raynaud syndrome?
Medications are generally considered when those conservative, non-pharmacologic measures aren't providing sufficient relief from symptoms, or if the attacks are very frequent or severe, or if there are signs of complications like ulcers starting. Some individuals with primary RS might only need to use medications during the colder winter months when attacks are worse.
Makes sense.
It's important to understand that the goal of medication in Raynaud's is usually to reduce the frequency and severity of the attacks rather than to provide a permanent cure. It's also worth noting that medications might be less effective in cases of secondary RS where there is significant fixed narrowing or blockage in the arteries. You can only dilate a vessel so much if it's already structurally damaged.
Good point.
Furthermore, clinical trials for Raynaud's often show a notable placebo effect, sometimes 20–40%, where people in the control group also experience some improvement just by being in a study. So it's important to keep that in mind when evaluating the results of drug studies. The actual drug effect needs to be significantly better than the placebo effect.
What are some of the main types of medications that are used to treat Raynaud syndrome? I know calcium channel blockers are often mentioned first.
Yes, calcium channel blockers, particularly those in the dihydropyridine class, like nifedipine, are often considered the first-line medication prescribed for Raynaud's and have been studied the most expensively. These drugs work by helping to relax the smooth muscles in the walls of blood vessels, leading to vasodilation and improved blood flow.
So they open up the pipes.
Essentially, yes. Studies have shown that nifedipine can be effective in reducing both the frequency, maybe by 66% in one trial, and the severity, maybe 33% in a meta-analysis of Raynaud's attacks. Although a recent Cochrane review suggested the effect might be fairly modest in primary RS, reducing attacks by maybe 1.7 per week compared to placebo.
Still better than nothing.
For many people, yes. Other calcium channel blockers that might be used include nicardipine, amlodipine, and felidipine. Common side effects of these medications can include low blood pressure, flushing, swelling in the ankles or feet, edema, and sometimes palpitations or dizziness.
Okay. What about other types of medications? The source also mentioned alpha-adrenergic blockers. How do they work in Raynaud's?
Right, alpha-adrenergic blockers. Alpha-1 blockers, specifically, such as prazosin and the longer-acting terazosin, can also be helpful. These medications work by blocking the action of norepinephrine on those alpha-1 receptors in the blood vessels, which helps to prevent them from constricting excessively.
Counteracting that nerve signal.
Exactly. Prazosin has shown some modest benefit in reducing the number of attacks in both primary and secondary RS. Potential side effects of alpha-1 blockers can include low blood pressure when standing up, what's called orthostatic hypotension, and maybe palpitations. Alpha-2 adrenergic blockers, targeting those receptors we discussed earlier as being key in cold sensitivity, have generally shown more mixed results in clinical studies for Raynaud's, unfortunately.
Okay. And what about prostaglandins and those PDE5 inhibitors like sildenafil that are also used for other conditions like erectile dysfunction? How do they fit in?
Prostaglandins, such as epoprostenol and iloprost, are potent vasodilating agents. They're typically reserved for more severe cases of Raynaud's, particularly when there's critical ischemia, meaning severely restricted blood flow, threatening tissue viability, or actual digital ulcers.
So for the really tough cases.
Yes. Intravenous iloprost, in particular, has been shown to be effective in promoting the healing of digital ulcers and reducing the severity and frequency of attacks. Some studies even suggested its effectiveness might be comparable to oral nifedipine for ulcers. However, oral forms of prostaglandins have generally been much less effective, unfortunately.
Okay. And the PDE5 inhibitors.
Phosphodiesterase type 5, or PDE5, inhibitors like sildenafil, Viagra, tadalafil, Cialis, and vardenafil, Levitra, work through a different mechanism. They increase the levels of a signaling molecule called cyclic GMP, which leads to smooth muscle relaxation and vasodilation. Studies have indicated that sildenafil can reduce both the frequency by about 33% and duration by about 44% of Raynaud's attacks, with the benefit appearing to be primarily in secondary RS. Tadalafil and vardenafil have also shown benefit in some limited trials. Topical sildenafil, applied as a cream, has also been investigated and showed some promise in increasing blood flow to the hands.
Are there any other medications that are sometimes used for Raynaud syndrome? Seems like quite a few options.
Yes, there are several other medications that might be considered depending on the specific situation. Endothelin receptor antagonists, like bosentan, target that potent vasoconstrictor ET1 we talked about. They've been used mainly in the management of Scleroderma-associated Raynaud's to help prevent the formation of new digital ulcers, although they don't seem to have a significant effect on healing existing ulcers or reducing pain or disability scores much. These medications can have potential side effects, including elevated liver enzymes and fluid retention, so monitoring is needed.
Okay.
Nitrates, such as nitroglycerin, can also cause vasodilation. They're well known for treating angina, but they are often not used as first-line treatments for Raynaud's due to potential side effects like headache and low blood pressure. However, topical nitroglycerin ointment has been effective in some trials for both primary and secondary RS, applied directly to the fingers.
Any others?
A few more mentioned. ACE inhibitors like captopril improved blood flow in one study but didn't reduce attacks. Angiotensin II receptor blockers, or ARBs, like losartan, were actually found to be more effective than nifedipine in one particular study for primary RP. And even some serotonin reuptake inhibitors, SSRIs, like fluoxetine, Prozac, typically used for depression, have shown some potential in reducing the frequency and severity of Raynaud's attacks, with one study suggesting comparable efficacy to nifedipine. So lots of potential tools in the toolbox.
It really sounds like there's a pretty wide array of medications that can be tried, and the choice really depends on the individual specific situation, the severity of their symptoms, side effects, and maybe whether it's primary or secondary. What about when medications aren't enough to manage the condition? Are there any surgical or more invasive treatment options available?
Yes, surgical intervention for Raynaud syndrome is generally reserved for severe cases that haven't responded adequately to comprehensive medical management and are at high risk of complications like non-healing ulcers or gangrene. Some of the surgical and interventional options include botulinum toxin, Botox injections, sympathetic nerve blocks, sympathectomy, which involves surgically interrupting the sympathetic nerves that control blood vessel constriction.
Cutting the nerves.
Essentially, yes, or blocking their function, and also the use of spinal cord stimulators. In very severe cases where tissue damage has already occurred and isn't healing, local debridement, removal of dead or infected tissue, or even amputation of part of a finger might unfortunately be necessary as a last resort.
I've heard of sympathectomy. How is that typically performed for Raynaud's, and how effective is it considered?
Well, sympathectomy for primary Raynaud syndrome is not commonly performed these days. The reason is a relatively high rate of symptom recurrence over time. The benefits often don't last. However, in cases of critical secondary Raynaud's where there's a significant risk of tissue loss, a procedure called thoracoscopic sympathectomy.
Minimally invasive.
Yes, using small incisions and a camera in the chest might be considered to try and improve blood flow and preserve tissue. Lumbar sympathectomy, targeting the sympathetic nerves in the lower back, has generally been found to be more successful and durable for managing vasospasm in the lower extremities, like the toes. There's also a more localized surgical procedure called adventitial stripping of the arteries in the hand and fingers, where the outer layer of the blood vessel containing some nerves is removed. This has shown some anecdotal success in relieving pain and healing ulcers in very refractory cases, but it's generally reserved for the most severe situations due to its complexity.
And what about botulinum toxin, like Botox? I wouldn't have immediately thought of that as a treatment for Raynaud's. How does that work?
It's actually being used with increasing frequency as a potential treatment option, particularly for painful Raynaud's or ulceration. Botulinum toxin can be injected carefully around the digital neurovascular, bundles the clusters of nerves and blood vessels in the fingers. This essentially acts as a chemical sympathectomy.
How so?
It works by blocking the release of neurotransmitters like acetylcholine and possibly norepinephrine from the nerve endings, which prevents the signal for vasoconstriction from getting through effectively. Case series and smaller studies have shown that botulinum toxin injections can help reduce pain, improve the healing of digital ulcers, and increase blood flow in both primary and secondary Raynaud syndrome. While some randomized controlled trials have shown some short-term benefits, the effects don't always appear to be long-lasting, often needing repeat injections.
Interesting application. And what about those other options mentioned? Nerve stimulation and spinal cord stimulators.
Transcutaneous electrical nerve stimulation, or TNS, applied to the skin, has been tried for Raynaud's with kind of variable results in terms of inducing vasodilation. Spinal cord stimulators, which involve implanting electrodes near the spinal cord and are typically used for managing severe chronic pain conditions.
Like failed back surgery syndrome.
Exactly. These have also been explored in the context of severe secondary Raynaud's, particularly in patients with tissue damage and intractable pain. Some studies have shown promise in reducing pain and potentially promoting the healing of digital ulcers in these very challenging cases. But again, it's reserved for highly selected severe situations.
It sounds like there are a lot of different treatment approaches, ranging from simple lifestyle changes to complex surgeries, and it really needs to be individualized based on the specific characteristics of each patient's condition. What about alternative or complementary therapies? Are there any that have good evidence to support their use for Raynaud syndrome?
Several alternative therapies have been investigated with varying levels of evidence. Acupuncture has shown some evidence in smaller studies for potentially reducing the frequency and severity of attacks, particularly in primary RS.
Okay.
Ginkgo biloba, an herbal supplement thought to improve circulation, has had mixed results in clinical trials. One older trial showed some benefit, while a later pilot study did not find a significant effect. Fish oil and the amino acid L-arginine, the precursor to nitric oxide supplementation, have generally failed to show significant benefit in controlled trials for Raynaud's.
So, not much strong evidence there.
Anything else? Laser therapy, including both low-level laser therapy and a specific type called multi-wave locked system, or MLS therapy, has shown some encouraging results in certain studies. Reports mention reduced frequency and intensity of attacks and objective improvements in microcirculation. One marker, angiopoietin-2, might be useful for monitoring response.
Let's just track.
Ozone therapy, administered in various ways, was reported to improve ulcer healing rates in one study involving systemic sclerosis patients with Raynaud's, but more research is needed. High-intensity interval training, or HIIT, has been shown to improve overall cardiovascular health and quality of life measures in patients, and arm cranking exercises specifically might be particularly beneficial for improving vasodilation in the hands.
Exercise is usually good.
Generally, yes. Finally, extracorporeal shockwave therapy, or ESWT, which uses focused sound waves and is typically used for things like breaking up kidney stones or treating tendinitis. This has shown some preliminary positive results in one study for systemic sclerosis patients with Raynaud's. They reported reduced ulcer size and number and improvements in other clinical indicators after treatment, but again, very early days for that.
Wow, that's a surprising number of alternative therapies that are being explored. Some sound quite experimental. It definitely seems like the field of Raynaud's management is still evolving with ongoing research into various approaches. Now, our source also includes a helpful chapter algorithm that summarizes the approach to managing Raynaud phenomenon. Can you briefly walk us through how that decision-making process typically works according to the algorithm?
Certainly. The algorithm generally starts with the initial presentation, a patient reporting cold-induced digital ischemia, those color changes. The next crucial step typically involves performing vascular laboratory testing and serologic blood work. This helps differentiate between cases that appear primarily vasospastic and have negative blood tests, which strongly suggests primary RS.
More common, benign type.
Right, versus those that show evidence of fixed obstruction in the vascular lab and/or have positive serology, like a positive ANA or RF, pointing towards secondary RS and the need to investigate an underlying cause.
Okay, so sorting into primary versus secondary first.
Exactly. Then, the management strategies diverge based on that classification and also critically on whether or not the patient has developed digital ulcers. For primary RS without ulcers, the initial approach usually involves conservative measures, education, cold avoidance, maybe stopping smoking. If that's not enough, the algorithm suggests moving to first-line pharmacologic therapy, typically the calcium channel blockers like nifedipine.
And if there are ulcers, or it's secondary?
If digital ulcers are present, or if the initial treatments are not effective even in primary RS, the algorithm typically guides towards considering second-line medications, perhaps PDE5 inhibitors, or maybe intravenous prostaglandins like iloprost, especially if ulcers are severe or progressing. Then, if medical therapy fails to control severe symptoms or heal ulcers, surgical or invasive options like sympathectomy or botulinum toxin injections might be considered further down the line. For cases that are suspected or confirmed to be secondary RS based on the initial workup, the algorithm emphasizes the parallel importance of diagnosing and specifically treating the underlying medical condition, the scleroderma, the lupus, etc., alongside managing the Raynaud symptoms themselves. It really outlines a logical, stepwise approach to management based on the cause, the severity of the symptoms, and the patient's response to different treatments.
Okay, that gives us a really clear overview of how doctors typically approach the diagnosis and management of Raynaud phenomenon, navigating through those different steps. So to bring our deep dive to a close, what would you say are the most important key takeaways from our discussion today for our listeners?
Yeah, I think the key takeaways are first that Raynaud phenomenon, or Raynaud syndrome as we should probably call it, is this complex condition characterized by an exaggerated narrowing of blood vessels, usually in the fingers and sometimes toes, triggered by cold or emotional stress. Second, it's really important to recognize that there are two main forms. Primary RS, which is often relatively benign and doesn't have a known underlying cause, and secondary RS, which can be a sign of a more serious underlying medical condition, often a connective tissue disease.
That distinction is critical.
Absolutely. Third, understanding the multitude of factors that can contribute to Raynaud's, from issues with blood vessel function itself, both dilation and constriction, problems with nerve control involving those alpha-2 receptors, to hormonal influences, genetic factors, and various external risk factors like vibration or certain drugs, is crucial for both understanding the condition and developing effective management strategies. And finally, there's a wide range of diagnostic tools available to help sort this out, and importantly, a similarly wide range of treatment options, emphasizing that the management of Raynaud syndrome needs to be highly individualized. It can range from simple preventative measures and lifestyle modifications, all the way up to various medications and, in some severe cases, surgical or interventional procedures.
And it certainly sounds like ongoing research continues to deepen our understanding of the underlying mechanisms and to explore new and potentially improved ways to help those living with this often troublesome condition.
Precisely. And this raises a really interesting question, maybe a final thought for you, our listener, to ponder. Considering this increasing exploration of alternative therapies, our growing understanding of the intricate interplay of vascular, neural, and humoral factors, and the push towards more personalized medicine, what new understandings or perhaps innovative treatments might we see emerge in the future for individuals affected by Raynaud syndrome? Maybe some of the aspects we've discussed today have resonated with your own experiences, or perhaps just sparked your curiosity about how our bodies regulate temperature and blood flow. If so, we certainly encourage you to explore this fascinating area further.